Okay, parents, your kids are going to turn out just fine.
This episode of the podcast is brought to you by FOCO. That's FOCO, F-O-C-O. If you are a parent of a child or teen with ADHD, you know how challenging it can be to keep them focused and engaged. FOCO is the all-natural solution for ADHD, whether it's for school, homework, or just everyday activities. FOCO helps your child or teen stay calm and attentive. Before trying prescription drugs like Adderall that can come with harsh side effects, I recommend you try FOCO. Visit ThinkFOCO, that's ThinkFOCO, thinkfoco.com for more information. Welcome to the Your Kids Will Be Fine podcast. This is Dr. Michael Malofsky, board-certified pediatrician and parent of 7. Every episode of Your Kids Will Be Fine, we talk to parents about the information overload and the information era of parenting and help us sort through the areas where we tend to be overloaded with information and what decisions to make and what decisions are best, and hopefully to help us feel better about our sustainable parenting choices and feel less anxious about the parenting choices that we make, hopefully so you know that, hey, your kids will be fine. And this is the second part of our series on newborns. Last session we did cover vitamin K, Hep B vaccine, circumcision. We covered breastfeeding versus bottle feeding. So we're going to cover again the other major areas of parenting decisions and choices that we make when we have a newborn. Specifically, we're going to talk about the great co-sleeping debate, which is, I think, can be very confusing because there is, in general, we have difficulty talking about risk and risk tolerance when we make parenting decisions. We're also going to talk about fever in newborns, which is different than dealing with fever when your kids are older. And we're going to talk about the decision to vaccinate. So we're going to cover a lot of ground. So first, let's talk about how normal newborns behave after you bring them home. When parents come to me and they're worried about whether their newborn's behavior is normal, I try to frame the discussion in terms of trimesters. I ask parents about what was your baby doing the last few months or two during your pregnancy. And most people, let me know that they didn't really notice the baby much when they were up and around and out and about during the day. And they did notice the baby's movements and notice the baby a lot more when they were getting ready for bed and lying down in bed. Then the baby would be moving and much more active. And so that software pretty much runs in the same way after your baby is born. I kind of talk about it as the fourth trimester, that first month or two after the baby's born, where your baby during the daytime hours, especially the newborn period, is really sleepy, especially for the first few days, may be really hard to arouse and get to eat. And the baby is much more restless and much more active and much more demanding for a few hour window, especially after the sun goes down at night. That's when you hear your baby grunting and squirming and moving around. And if you've never had a newborn before, you wonder if your baby's okay or if there's something wrong. That's when babies tend to cluster feed, also if they're breastfeeding. So babies run that software for like the first 2 months, and then they slowly develop a circadian rhythm that reflects more, sort of typical baby patterns, where there'll be sleep cycles and wake cycles and feeding cycles that are kind of cycle through the day and the night. So that's the first thing to know about newborn behavior. So let's talk about co-sleeping. The concern about co-sleeping has to do about safety of our infants. Sudden infant death syndrome, which is now referred to as sudden unexpected death of a newborn, those rates have really dropped off and stayed very low levels since we've instituted back to sleep. And I just put out a video on this because many moms, especially new moms, come to me and I ask them how they're doing with eating and sleeping, and they're breastfeeding. And this one mom said, honestly, I'm afraid to tell you what I do because I'm concerned that you'll judge me, or I'm concerned that you'll report me for being unsafe. And I asked her what was going on, and she said that she sleeps with her baby next to her because when she's breastfeeding, it's just easier to pull the baby in and nurse her baby, and everyone sleeps better. And she sleeps better, and she feels like she's parenting better. And then it sparked an open discussion about what are the real risks and how are those risks discussed and communicated to parents. I think one of the better, well-framed discussions that people can look at when they are searching and buying resources online is Emily Oster. Emily Oster is a data scientist, and she wrote a book called Crib Sheets. And she talks about the actual data behind these recommendations that are given to parents through the AAP and other medical and parenting bodies. But it's important to understand that the risk is not uniform, and that the discussion about risk of co-sleeping with your baby can be a nuanced one. That there's no question that there's some elevated risk, and in this case we're not talking about SIDS, but we're talking about accidental suffocation of your newborn when you share a sleep space. However, that risk is definitely variable based on individual scenarios and situations. As many of you know and probably have read, that bed sharing and co-sleeping with an infant, especially when you're breastfeeding, is considered normal in most cultures and countries around the world, and we're the only country that really considers this dangerous or abnormal. One reason for that is because the way that we, shall we say, construct our sleep space, the kind of beds and what we sleep on, is very different than other countries that also bed share, which contributes to the risk of accidental suffocation. But what we do know is that there are certain factors that, if are absent, the risk of accidentally suffocating your infant is exceedingly low. So what are those? One, if you are breastfeeding, it protects your baby from accidental suffocation. Mothers who are breastfeeding instinctively share their bed space in a safe way and know where their baby is when they're nursing and sleeping with their infant. Two, that no one is overweight or obese. Three, that there's no secondary smoke exposure. Four, that your newborn is a healthy, full-term, normal-sized newborn and your child wasn't small for age or premature. And if none of those factors are present, the actual risk is exceedingly small that you are endangering your baby. And this is once again mostly to do with the study around breastfeeding infants. If formula-fed infants, it's not clear whether it's the same. So the point of this is that we can have an honest and open, nuanced discussion, and that people should be able to make informed choices about what works best for them, knowing what those risks are. So I think that that's a really important topic to be able to discuss openly, and to be able to interpret the data that you're given in a way that so you can really apply it to a real-world decision that you want to make that's best for you. Next, let's talk about fevers in newborns, because I think that every time when you have a newborn, a child, let's say a child under 3 months of age, and you're going to be counseled at your doctor's office to be very wary of an elevated temperature. So first, how do you know if your baby has a fever or an elevated temperature? Your baby always feels warm, especially their head. When a baby has a fever, they clearly don't feel well. Their behavior will be different from their baseline behavior that you are used or got used to seeing and managing, getting in the process of getting to know your baby. Your baby doesn't seem right. And so let's say you want to take your baby's temperature. There really is only one accurate way to assess a fever, the presence of a fever in a newborn. It is taking the temperature under the arm, using a forehead strip, using an ear thermometer in a newborn are notoriously inaccurate and will give you possibly misleading information, which can be dangerous. Taking a simple rectal temperature with a digital rectal thermometer is safe, it's easy, it's not hard to do, and it really is the only accurate way to assess if your baby has a fever. What you want to do is make sure your baby is unbundled, it is not overheated, written inside an excessive amount of blankets or coverings that can falsely elevate your baby's temperature, and make sure that your baby is kind of open to air and sort of equilibrating with the regular room temperature for a good 5-10 minutes, and then take a digital rectal temperature. A temperature of 100.4 or higher is considered a fever, so why do we worry about the presence of a fever? If you have a 9-month-old or even a 6-month-old and you tell me that you have a fever and your child looks okay, we really don't worry too much, and we just counsel you to watch it. First thing is that newborns, you really can't interpret whether they look okay or not, because they always look kind of sleepy, and it's really hard to tell if they look well or not just from observing behaviors. They could just be seemingly more tired. It's hard to know. They're hard to interpret. Two is that a baby's immune system is still developing and isn't quite as strong or developed as an older infant, hasn't had the benefit of being vaccinated against serious bacterial infections like pneumococcus or Haemophilus influenza, which are really dangerous. And in fact, the most dangerous infection that a baby is vulnerable to in the first 3 months is actually something the baby can get from being born, which is called group B strep. And even though you may have been tested for it and you may have been negative and or treated for it, babies can still get it because it can still show up even if you tested negative. So let's say a newborn under 21 days of age with a rectal temperature of 100.4 or higher is considered an emergency, and your child needs to be evaluated urgently by a qualified pediatric center, not usually a freestanding or commercial urgent care. You need a pediatric emergency department to look at your child and to properly manage them. Between 21 and 28 days, there's a slightly different approach, but still considered very urgent. From 28 days to 60 days, between 1 and 2 months, it's still considered urgent, but the evaluation is structured slightly differently. And then between, over 2 months, again, it's considered urgent to be evaluated, but might even be able to be evaluated at your doctor's office prior to being seen in an emergency room. And once again, the approach in evaluation is slightly different. When you have a brand newborn, let's say under a month of age, the evaluation, if your child has a legitimate fever, usually involves blood tests and urine tests and maybe even a spinal tap to assess for the presence of meningitis, since babies are still very vulnerable to these types of infections even after they've been born. So the point is that regardless of what you may read in other alternative areas, pretty much every major pediatric resource lines up that a fever of 100.4 or higher in a newborn, especially under 1 to 2 months of age, is considered an emergency issue. You need to speak to your doctor and will likely need to be seen urgently in a medical facility that treats children. So I hope that that's clear. So next and last, let's talk about the decisions around vaccination. In your first few visits to your doctor, you're going to be asked about what you are choosing to do with childhood vaccines. Childhood vaccines are, as we talked about last time, you're offered a hepatitis B vaccine in the hospital. Then the regular vaccine series starts at 2 months, 4 months, and 6 months. And what those vaccines are, there are many great vaccine resources, and you can read about them and their ingredients. I'm not going to go over and debate all of those. However, I do recommend the Children's Hospital of Philadelphia Vaccine Resource Center, which they have online, which was written by the leading experts in vaccine science and immunology and infectious disease in the pediatric world, and are very well written, clearly written for parents to clearly understand, so they can understand what they are giving their child and what the risks and benefits are. In general, the reason why we offer so many vaccines during this window, during this very young age, is because we are recognizing the fact that the immune system is going through a very critical window of development where it's rapidly expanding and learning how to protect the baby. And during this window of immune expansion, when we then challenge the immune system with these vaccines, and it's rapidly taken up by these vaccines are taken up by the immune system and produces a robust immune response, which will produce long-lasting protection for the baby as the baby grows and the immune system develops. And that's why this critical window is the target for all of these vaccines up front very early. No, it does not overwhelm the baby's immune system. That is a myth. Your baby's immune system is processing millions and millions of elements of exposure just being out in the world and living every day. We're not stressing the baby's immune system beyond that. The ingredients, which there's plenty of misinformation about, but I think that parents can have a clear-eyed understanding of what those ingredients are, including formaldehyde and aluminum and all those things that sound really scary, and what amounts they're there and what that means as far as exposing your baby to them. And that's written very clearly in the Children's Hospital of Philadelphia Vaccine Resource Center. I think that, once again, everyone should read it and take a look, and it answers, I think, every possible question you can have. So, in my office, I want to give parents as much autonomy as I can in making the choices they want to make for their children, while at the same time protecting the community of children that I have to protect. My office attracts a large number of special needs children, NICU grads, kids who were critically ill and are being discharged from the hospital. So I have a responsibility to protect all of them, but I also feel a responsibility to allow parents to make decisions that they feel comfortable with. So in my office, I mandate not every vaccine to be, if you don't want to vaccinate and do certain vaccines, I leave it up to you. I don't recommend it, but I leave it as your choice. However, I do need parents, if they're going to be part of our office, to give their child the DTaP vaccine, which covers whooping cough, tetanus, and diphtheria, although it's the whooping cough that I really need them to have so they don't accidentally transmit that to other vulnerable children in my office. The polio vaccine and the MMR vaccine and chickenpox vaccines, because those are the viruses that can be and infections that can be spread easily in an office without knowing it, before your child may have symptoms, that can be devastating to a young, vulnerable, medically fragile child. All the other vaccines that parents can research, and they can choose to do that at their own pace. If they choose not to, I try to explain to parents why that may not be a good idea or what their child's at risk for. But those are the vaccines that I require. This past 2 years, we now have the ability to protect kids against RSV, and it comes up in the newborn period, so I want to address it. Many of you know RSV, which stands for respiratory syncytial virus, is probably one of the most dangerous respiratory viruses, especially for young infants, especially under 8 months of age. There is a very high rate of hospitalization, a very high rate of intensive care unit and hospital admission, and a very high rate of severe long-term consequences and death even, because this virus causes such rapid and devastating respiratory symptoms. It can cause apnea in a newborn and sudden unexpected death as well in a very young infant. So now pregnant moms can get a vaccine which allows them to produce an antibody that's passed to the baby between weeks 32 and 36 of pregnancy, which can protect your baby from RSV. And we also have a version of an RSV. It's not a vaccine, actually. It's a monoclonal antibody shot called Beyfortus. This actually treatment has been around for many, many, many years. It was in the form of something called Synagis, which is only offered to premature babies who are being discharged from the hospital during RSV season. But now every child, newborn to 8 months, can get a single dose of Beyfortus, which can protect them for the entire RSV season. And the numbers in terms of how it protects infants is absolutely mind-blowing. It has an 80 or 90% reduction in the risk that your child will end up in the hospital or the emergency room due to an RSV infection. It doesn't keep them from getting an RSV infection. It just prevents an RSV infection from becoming serious. And in my practice, we're able to offer that to children as early as they come in for their first visit in the newborn period, all the way through about 8 months, and pretty much every insurance company is paying for it. So definitely a strong decision to protect your baby during the winter season. This is definitely going to be more of an issue for parents that have older children in daycare, or their infant will have to go to daycare, because that's where a lot of RSV exposure actually happens. If you have an only child at home who's going to be cared for at home and isn't exposed to other children outside the home on any level, you definitely can reconsider whether you want to do it. Your risk of exposure is much lower, but as you know, babies can be exposed to RSV unexpectedly, often through adult contacts as well. So that's part 2 of our series on newborns. The next podcast, we're going to be moving up to the decisions in infancy, 2 to 12 months, and all the decisions and things we have to think about around our young infants and babies at home. So looking forward to hearing from you. Please find our podcast on Apple, Spotify, and any platform where you get your podcasts. Don't forget to find us on our website, yourkidswillbefine.com, where you can download every episode, as well as on our YouTube channel. And we're looking forward to seeing you next time.